lastly, we'll just briefly go Mosunetuzumab. So Mosunetuzumab is the only drug approved for follicular lymphoma. This is a study that was presented by Dr. Buddy. Again, step-up dosing, 1 milligram on day 1, 2 milligrams on cycle 1, day 8, 60 milligrams on cycle 1, day 15, again, 60 milligrams on cycle 2, day 1, and then thereafter, again, 30 milligrams. Mosunetuzumab and glofitamab are given every 3 weeks. I forgot to clarify that point. Again, as I mentioned, with glofitamab, mosunetuzumab is also fixed dosing. So 8 cycles only if you get a complete response. If you do not get a complete response, you can go up to 17 cycles. And unlike the other 2 drugs in large cell lymphoma, there is no requirement for hospitalization. At the bottom, I put that they are exploring sub-Q dosing with mosunetuzumab, and here's the dosing schedule: 5 milligrams, 45, 45, and then 45 until either cycle 8 or cycle 17. This one has an overall response rate in this patient population of 78%, which is an important one. Complete response rate 60%. Unlike diffuse large B-cell lymphoma, overall response rate is an important parameter in follicular lymphoma because, again, this is a more chronic lymphoma, so you can live with this cancer. So you don't necessarily have to get a complete remission to have a durable outcome. The curve to the right is really more academic information, not very important. Just lets you know that in certain mutations, the response rate wasn't very different. The durability of response thus far, the median duration of response, time that you're on treatment, has not been reached. But 24 months, 53% of patients are still responding. Those in a complete response, meaning no evidence of cancer, the duration of complete response is 63%. Progression-free survival, time before the cancer has relapsed, is about 24 months, with 48% of patients still being in PFS without having a relapse. And then time to next treatment is not reached, and overall survival is not reached. So also very impressive sort of data for this patient population that receives this bispecific antibody. Now, again, CRS is still the major issue, a little bit different from the 2 drugs in diffuse large B-cell lymphoma. There isn't necessarily a step up or a step down. You see there are 2 peaks, one peak on cycle 1, day 1, and then another peak on cycle 1, day 15. Thereafter, the incidence of CRS decreases considerably. Majority of the CRS events are grade 1 and grade 2. As I mentioned before, grade 1 is generally the easiest to manage. Grade 2 does still require some hospital evaluation because, again, you may need other supportive medicines we can't give as an outpatient. And this table just sort of summarizes with mosunetuzumab versus odronextamab, which probably will be the next drug to get an indication. As you can see, overall response rate about the same, complete response rate about the same. The PFS at 24 months, about the same. Asterisk by odronextamab because they only reported out 18 months. So again, overall, these numbers appear very similarly. The incidence and usage will come into the simple fact odronextamab is a much more complicated treatment step up than mosunetuzumab, and then we'll have to see how safety plays out. So just to summarize, follicular lymphoma, there's only one bispecific antibody, makes sort of choosing easier, but where it fits is a bit complicated. Because follicular lymphoma, you can have a lot more treatments and you can use other drugs repetitively. It's a very crowded space. And with CAR T and follicular lymphoma, it's sort of a competition. There isn't a survival advantage that we know about follicular lymphoma. And so whether you use CAR T or a bispecific will be up to you and your treating physician and sort of how sort of your life sort of fits. A one-time treatment versus a treatment you'll get every 3 weeks, but will eventually still stop. With the sort of incidence of CAR T, you have to be near a CAR T center. You'll have to have social support. The bispecifics, more treatments, but again, can be given in a community setting. So as we move forward, I think these bispecifics will make a big impact in patient outcomes with lymphoma. More than likely, most of these drugs will move up. Either they'll be used in frontline with combination with chemotherapy, or they'll be used in a second line in combination with some of the other targeted drugs like lenalidomide in follicular lymphoma, and potentially chemotherapy in diffuse large B-cell lymphoma.